Welcome to Bipolar Talks, a podcast when we dive into real story, life experience, and all things bipolarity. So I'm Clément Bessard, the founder of Upstage, and today I'm really happy to welcome the Dr. Arjun Keira, who is a psychiatrist, educator, and also advocate on mental health. So he lived in Cumbria, and it's really interesting today to go into what question do you have in mind when you go and see a psychiatrist and you don't actually ask them. So I would love to let you introduce yourself, Arjun, and let's go on with that.
Great. Well, look, thank you for having me on your beautiful podcast. Like I said, my name's Arjun. I'm a psychiatrist based here in Canberra. I work around Canberra, Sydney, and a lot of ACT in New South Wales. I have an advanced training certificate in adult psychiatry, so that often includes a lot of people with bipolar disorder in particular. I also work with intellectual disability. I've been a consultant psychiatrist for about 3-4 years, and before that, we go through medical school, but I'm born and raised in Canberra, Australia.
Awesome. So it's what most people are wondering is how many patients you see a day, what is your typical day actually?
Oh, okay. Yes. So I think every psychiatrist is different. And one of the things I didn't realize when I first even joined psychiatry was just how broad of a discipline or a specialty it is. So you can have very different types of psychiatrists who will do very different types of work. For example, there may be some who work just in hospitals. So they may have, between 6 or 10 or maybe a bit more patients on their books. Obviously, it depends on how busy the hospital is. And sadly, there is a lot of understaffing. So a lot of psychiatrists are working quite a lot to look after more than the recommended 10 or 12 patients at a time. But, they may have this many patients. Then you may have people like myself, who's an outpatient psychiatrist, meaning that we see patients in clinic. And for me, I can see a max of 7 patients a day. I can get pretty exhausted by the end because it's 7 individual stories and 7 individual people who you want to spend time and effort into. And a lot of my patients are quite complex. Even our adult patients who do have bipolar disorder and everything, by the time they're seeing me, things are not right. They need more specific thought and treatment. Because if they're well, they're not necessarily seeing me. The other part is that I see patients with intellectual disability, and their cases can be quite a lot more complicated because there's many layers and they can't communicate for themselves properly, for example. Then you may have other psychiatrists. Maybe there's some who do research, who only see a few patients a week, or you might have psychiatrists who work in these sort of mega clinics who do a lot of maybe ADHD work, which is everything's quite straightforward and simple. So they may see 10, 12, 15 plus patients a day. But it depends really on the length of time and how much energy you have, I suppose, at the end of the day, and how long you need to spend with each patient.
Yeah, that's one of the things I'm always surprised, because you have psychiatrists who take a long time with their patient, and some other is really like a quick 10, 15 minutes. And so can you explain me the difference? Because for me, I feel it really depends, is your psychiatrist doing psychotherapy or not? And I think it's can you explain the difference? And how do you ask your psychiatrist? Because I feel some people, they don't even know.
Yeah, absolutely. Look, it's very tricky and it's very individual at the end of the day about how the psychiatrist wants to practice in a way that's good for them. And broadly speaking, all doctors and all psychiatrists have to work within a certain ethical framework and a certain legal framework. So they can see you as short or as long as they feel is appropriate. However, that framework still applies. So they have certain responsibilities, and if something, hopefully nothing terrible happens, but if something terrible does happen, they have a certain responsibility and they have their own insurance around that as well, right? So I suppose that those principles apply. However, beyond that, it's very tricky to know as to why one psychiatrist may spend longer with a patient, one may spend shorter, and it can be a variety of different reasons. Before we go into the individual of the psychiatrist, though, there is a few other layers to it. One is the model of care that the business is providing in private psychiatry, or in hospital psychiatry, or in public psychiatry, or even in a research institute. So what does the business want or feel that the model of care should be? Does that business feel that it is best to have 2 45-minute appointments as the initial assessment? Do they feel that it's better to have 1.5 hour appointment for the initial assessment? Or do they not want even an initial assessment? They only want, 20-minute ADHD, if there's just an ADHD clinic. So the model of care, whether you're in public, whether you're in private, and which kind of facility you're in, will dictate what or how your psychiatrist operates. The other layer to this is funding. So you have different funding bodies in the public sector. It's based on your state government. In research facilities, it's usually federal government combined with charities or non-government organizations. And in private practice, we have Medicare, which is our, a federal government healthcare funding body. And that has different rebates for certain time spots. So a 15-minute appointment gets a certain amount of rebate, a 45-minute appointment gets a certain amount of rebate. And a lot of the times, the model of care and the business of care in private practice is based around the rebates to try and get the max amount of rebate for your patient and trying to get the max sort of bang for buck, meaning the max amount of care that you can deliver in a certain amount of time so that both you and the patient are getting the most value for money. Obviously, we can't comment. These are sometimes corporations and businesses, and they will operate differently. However, generally speaking, most private psychiatrists will base their appointment times on the Medicare rebates. And for an initial appointment, I think it's like between 45 and 60 minutes. Beyond that, the patient doesn't get any additional rebate. So it can be tricky to do a 1 hour or 1.5 hour appointment in initial private practice. So that rebate and the government structure is something that psychiatrists actually ourselves advocate quite a lot for, to say that, look, patients are more complicated. Sometimes people need more time, less time, blah, blah, blah. And then the other factor is the person themselves, who you're actually seeing, because some people may have a more clearer case or a more simple case, and some patients may be more unwell or be more complicated. And most psychiatrists won't rush the experience. They will say, okay, we can get through as much as we can with this appointment, but you deserve more time. So let's catch up again, pick up where we left off. For myself, that's sort of how we base our care. Our initial appointment is 1.5 hours. And we try and get as much information and build rapport, meaning build a bit of trust in that 1.5 hours. But we're very clear to say that, look, if that 1.5 hours is not enough time, we've got more appointments to catch up so that we can fully understand the patient and help each other out as best as possible.
Yeah, it's really interesting. And it's really different in every country, I guess. But so it's really like, for example, I'm trying to understand the math here, because at the end of the day, the most important is to help the patient. But as a patient, you sometimes don't know, like, do you need a psychologist and a psychiatrist? Or is it enough to have only a psychiatrist? And you usually, at least from my vision of the thing, it depends a lot by how much time do you spend with a psychiatrist. Because some psychiatrists, as you say, they do like 20-minute meeting or 15 minutes. And then usually it's better to have a psychologist after it, because you're not going to do the same thing. The psychiatrist maybe is going to focus a bit more on the pills and on the medicine. And on the other side, as you say, some psychiatrists also do the psychotherapy part, and they do longer sessions. So how can you tell, and what can you ask, and how do you know as a person who as a patient, if you know or not? You know what I mean?
Absolutely. That is such a good question. And it's so important, because a lot of people, you're right, really struggle to understand this. And again, this is almost based, sadly or fortunately or unfortunately, I don't know, but it's based more on our government and our funding model rather than the actual process or the skills itself. So if we start with a psychologist, so psychologists, generally speaking, are cheaper than psychiatrists per appointment and per hour and everything like that. And there are more of them. So you have better chances of getting an appointment with a psychologist than a psychiatrist, generally speaking. And because there's more of them, the appointment, it's a bit cheaper and you easily access and that sort of stuff. A lot of psychologists are very, very good therapists. They may be CBT trained, but there are a lot of psychologists who will do subspecialized training, more for people, for example, who have bipolar disorder. And traditionally it used to be that psychiatrists have a more different type of therapy and psychologists quite different. But I think that overall it's quite shared in sort of skill set in actually delivering the care. The issue is that a psychologist, you'll only get a rebate for about 10 or 12 sessions from the government. So after that, either you have private health insurance or you pay the full price. So that's, I suppose, where the funding side of things come in. If we feel that, for example, a patient who has bipolar disorder is going through an acute relapse and has just come out through the other end, maybe 12 sessions of CBT based, a bit of sleep work, a bit of IPSRT work is enough for them. In which case you could say, look, you can access a psychologist, we can work on these.
Sorry, can you explain what is CBT? I think it's
important. Yes, we should. So we can do CBT work, which is cognitive behavioral therapy. It's just about addressing what kind of thoughts or automatic thoughts we have and how they influence our behaviors and how we can change some of our behaviors and subsequently address some of those automatic thoughts to help our quality of life a bit better.
Okay, so maybe quickly to explain, because that's one of the other things which I found really interesting is like there's different theory in psychology and in psychiatry. And it's like, depending on who you met, is going to have a different theory of doing things. Can you explain a little bit? Because I think it's also an important subject for, as a patient, you go in and you don't know if it's the theory you actually need.
Yes. Oh, that's a massive topic. I mean, we could almost have a podcast just on that. And I have to put a bit of a disclaimer that I'm not a psychotherapist itself. So psychiatrists can do, let me take a few steps back. All psychiatrists trained in Australia have to have psychotherapy as a part of their skill set. So psychotherapy is a very broad word. There's one which is CBT, which I just explained earlier, thinking about how we think, how we behave, how we feel, changing some of those around to improve our quality of life. All psychiatrists in Australia who are trained in Australia also have to do psychodynamic psychotherapy. So this is a different type of psychotherapy. It's more about structure and routine and the relationship between the psychiatrist and the patient. That therapy, every Australian trained psychiatrist has to do 40 sessions of psychotherapy with one patient. And the psychotherapy journey can be anywhere between 1 year up to 5 or 10 years. So it's a very intense type of psychotherapy that happens weekly for a long, long time. It's oftentimes based on what sort of things we've experienced in our past, even intergenerationally in our past and in our childhood and our development, and how those come out as an adult. So that type of psychotherapy is one type of therapy that people can deliver. CBT, which I just spoke about, is another type of psychotherapy that we can deliver. Psychologists will often do CBT because their training in Australia is very CBT heavy. So they are very, very good at CBT, one of the best that we have. And CBT is a very problem solution focused type therapy. So a lot of people find a lot of benefit in just having those 10 or 12 sessions of CBT when they're going through some life stresses, for example. I mean, there are plenty of other psychotherapies as well, but actually there's been some very, very big and interesting studies that show that whether you do just a conversation like a chat as a friend without any sort of structure, all the way into CBT, which is a very structured discipline type therapy, or psychodynamic, which is very free, but very more about the relationship and experimenting in the therapy program, all that sorts of stuff. As long as you have unconditional positive regard, you have reliability, you have accessibility, you have, I suppose, a relationship between the therapist and the patient, you will get better. Almost 90% of the time, you will get better, regardless of which therapy you choose. It's only about 10% of the difference that is actually the type of therapy that you choose. More is just whether you like the therapist likes you, they're available, and they're containing, they're able to actually give you the space that you can talk things out.
Yeah, thank you for clearing things up, because I think it's a good thing in Australia, to be honest. I like CBT, so it's cool.
Yes, absolutely. One of the other differences between psychiatrists and psychologists in Australia is that psychologists, we only have a 10-session rebate program, right? Or 10 or 12 or whatever. Whereas psychiatrists can do psychotherapy appointments as part of their general appointments. So that's can be up to, I think, 60 or 80 or something appointments a year. And then you can apply for, or not apply, but there's a special code that you can use when it goes beyond this many number of appointments too. So whereas a psychologist could only see you 10 or 12 appointments a year, a psychiatrist could see you up to 200 or so appointments a year. So even though psychiatrists are far fewer and it's harder to access, they are more government sponsored to give long-term psychotherapy.
Yeah, and I think it's important also to explain the difference from a psychiatrist and a psychologist and a therapist. So to be really quick, psychiatrist is a doctor. So he's allowed to prescribe medicine, he's allowed to give a diagnosis. A psychologist is not a doctor, but is more focused, as you say, on psychotherapy. So on CBT, and then you have therapists, which it's not in the box. Let's say like it's not an official training, but they're still doing kind of psychotherapy. If you have anything to add, Arjun, I'd be happy.
Absolutely, absolutely. That's exactly right. Usually how I describe it is that a psychiatrist is a specialist doctor who does diagnosis, who does treatment, and they will often treat more moderate to severe mental illnesses. Whereas a psychologist is kind of like a pharmacist. So you imagine your community pharmacy, there's someone who dispenses treatment. So, in a usual GP setting, you might get a prescription and then the pharmacist gives you the medication. So in psychologists, what would happen is that a psychiatrist would say, oh, you should try some CBT. And then the psychologist will dispense or provide you that therapy. They can also do basic diagnostic work. So just like in a pharmacy, if you have a rash or something like that, you can go into a pharmacy rather than seeing a doctor. Same way, psychologists can often do some basic diagnostic work. And then psychologists themselves have a myriad of subspecialties. So there'll be psychologists who can do very intense psychotherapies. There's psychologists who can do reporting and do more evidence-based diagnostic work. They're very, very skilled psychologists around, but they will do a lot of additional training. I think it's very important that you mentioned therapists as well, though, because there actually isn't really much of regulation in Australia about who calls or doesn't call themselves a therapist. So you can have some therapists who, for example, are nurses or social workers or something like that, and they are incredible. They are very, very good. And they have done years and years of training and work around it. Conversely, you might also meet someone who's done a 3-week course and calls themselves a therapist as well. And because they don't have the experience and the training, they may not be as effective. So it's very important, if you just see the word therapist, to work out what this person's skills actually are and whether you feel that those skills are enough for you.
Yeah, it's exactly that. Like, in a way, you have good and bad people in each field. But when you go and see a psychiatrist, at least is a doctor. So he had a well-structured education, and that he has someone to control his work also, because there's a deontology and he cannot do whatever he wants. Where a therapist, you really have, they're really good therapists, as you say, but you really have to check a bit more the background. Like, okay, is it really a good fit? Does he has like review? He has been recommended or not by someone else, this type of thing. So just check a little bit more the box. But you say it's really good therapist, as you say, but it's a different, like, it's not well or like structure kind of education. I'm coming back to our first point because it's really the question I ask myself, because I come from France, and when I arrive in Australia, I'm like trying to discover a little bit how it works. And as you say, there's different time of practice. So depending on who you're going to see and depending on how long you're going to see the person. And to come back into that, like, so what, because there's different time of rebate, as you say. And I think it's important as a patient to understand how it works, to know, like, what should you what should you expect from a session, depending on how long does it last. So can you go a little bit further and explain the different type of psychiatrists and why they do different timing and why you should expect on each of those timing depending on the length of the time? Yeah.
Yes. Look, that's a really good question. And this is actually a question that it's not just patient specific. This is other doctors and other people don't understand what it takes to be a psychiatrist and what it does things. So gold standard or a full psychiatric assessment takes 3 hours. So we would say that if a patient comes into ED and we want to treat them in a gold standard way, And that's gold standard. That's not saying that, if it's someone's homeless, I'm going to build them a house. We can't do that sort of stuff. But if we want to treat them in a way that we would treat our relative or our friends or something like that, each patient would take 3 hours when you first meet someone. Obviously, there can be longer if things are more complicated, or shorter if things are less complicated, but overall it's 3 hours, right? And then it sort of changes from there. So generally speaking, if you use that same rule, you would expect that you would need to see your psychiatrist for 3 50-minute appointments, for example, for them to fully understand you, or understand you enough that they can develop some really good treatment for you. If the situation is more simple, for example, I'm stable, I'm well, I've just ran out of lithium, I've been well for a long time, I've been, this and that, blah, 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 blah. Life is going okay. Yes, there are ups and downs, but it's not too much of an issue. Then you would say, okay, well, maybe one appointment is enough, and you can get a good amount of information from there. Usually speaking, in my experience, it takes about 50 minutes just to get a good idea of the patient and their demographics, meaning where they live, what do they do, who they live with, their symptoms at the moment, so what kind of symptoms they're experiencing and the severity, or if it's in remission, and a little bit of background work, such as what kind of supports they have, if any drug and alcohol is in the picture, their financial situation, family history, those sorts of things. That alone, you can fit in about 50 minutes, or 50 minutes or an hour. And in fact, in our assessments, so as we train to be a psychiatrist, we have to be able to get a decent amount of information to be able to establish some sort of plan with the patient within about 45 to 50 minutes. That's our assessment, and we get assessed about 6 or 8 times a year formally for 5 years straight to check that we can do that. So you should be able to, in an ideal situation, have an appointment with your psychiatrist for about an hour, and they should have a reasonable understanding about what they're going to do. Obviously, if the situation is more complicated, it's not fair on you or the psychiatrist to have it in that time. And sometimes if the situation is very simple, such as just ran out of medications and otherwise life is going okay, then you might be able to do it in about 20 or 30 minutes. I don't think that really there would not be psychiatrists in Australia who are seeing patients initially for the first time in less than 20 minutes or half an hour. That just really wouldn't be that common at all, unless it's just, like a handover of a patient and it's just a script, like something very, very, very simple.
Okay, because you have this initial phase, which is really important, where basically build the plan with a patient. And then you have this kind of like stable phase, let's say. And then how does it work? Because then because you need to have a lot of information at the beginning, and then maybe after 3 months, okay, so how does it work? Because it's also a different type of an appointment, as you say. It's like those short appointment and longer appointment. And sometimes I feel some psychiatrists that are really doing psychotherapy, and some other are just mainly focusing on like the treatment and doing shorter. So what question should I ask myself as someone who is a patient?
Yes, that's really good. So yes, you would have an initial phase, regardless of where your illness is going or what you want. The initial phase is going to look relatively similar for a lot of people, depending on your complexity. And that's because there is a standard amount of information that we need. And also there's a standard amount of warmth that we need. We need to be able to connect with one another so that we can actually have trust and we can move forward together collaboratively. And arguably that's important in all healthcare and all medicine, not just psychiatry. Whether you're meeting your psychiatrist or whether you're meeting an oncologist for a new cancer diagnosis, but you need to be able to have some faith and some trust in that doctor and their team. And so that will look sort of the same for everyone. But from there, the sort of maintenance phase can be quite different depending on person to person, absolutely. Some psychiatrists and patients together will say, wow, there's a lot of things going on in your life and in your mind, and maybe psychotherapy would be very helpful for you. And if the psychiatrist feels confident that they can deliver that psychotherapy, and the patient feels that, I think I would like this psychiatrist to deliver the psychotherapy, then they can meet that psychiatrist, for example, weekly and do psychotherapy with that person. And that can be CBT based, that can be psychodynamic, talking about childhood and these other things, or it can be all sorts of other therapy in the middle. Other times the patient may say, I think I need a therapist a little bit, but, this psychiatrist is very busy. It's very hard to get an appointment with them. Or this psychiatrist is not very skilled in this type of psychotherapy. Or I already have a psychologist, or I would like to try someone else or something like that. In which case you may just see your psychiatrist every month or every 6 months, or however often you need to check in and make sure that you're okay, but get your therapy delivered elsewhere as well. Overall, I can't think of any mental illness that doesn't have a therapy component that is helpful. So in gold standard practice, if we want the best of care for ourselves, for our family, for everyone like that, there should be some level of psychotherapy involved, whether that's a small amount, whether that's even self-help or some group therapy or something like that, or whether it's very intense psychotherapies, weekly or twice weekly with a psychiatrist. And I think it's probably where the sort of shared decision-making and collaboration really comes into place. And that can only really happen if you really know your patient and your patient really knows you as a psychiatrist.
Quick break. Can you let us a review on Apple Podcasts or the platform of your choice? It really helps us break the stigma around bipolarity. Let's get back to the episode. Yeah, so I think it's really important what you're saying, Arjun, is like, okay, so there's this initial phase, which is roughly the same, let's say, 50 minutes meeting. And then do I need a psychiatrist for the psychotherapy? And then the session will stay about, let's say, 45 minutes per session. Or am I going to keep this psychiatrist, but more for the treatment and have a psychologist, for example, aside? And then maybe the session is going to be like every 3 months, and then it's going to be shorter session, and I will do the psychotherapy with my psychologist. So that's really the question you have to ask yourself. Like, if you see a psychiatrist for like 15 minutes every time or 20 minutes, usually you need something outside for psychotherapy. If your psychiatrist is doing 45 minutes, let's say every 2 weeks, maybe you don't need a psychologist aside. But it's getting more and more rare. Personally, I have a psychiatrist and a psychologist, and I work with both of them. And one of the things also I'm trying to understand, Arjun, is like, because you say on rebate, there's 2 different kind of fees. So there's like the government is with Medicare and insurance is paying a different amount depending if you do psychotherapy or if you do not. How does it work?
Yeah, the initial fees are much the same. And for a lot of appointments, the continuing follow-up appointments, whether you're doing just psychiatry, which might be a 30 to 45 minute, or you may be doing a bit of combined, which might be, to 50 minutes or an hour, or if you're doing psychotherapy, I think it really depends on the psychiatrist, what they're doing with you, what you're doing with them. And also, sometimes appointments can run over, you're thinking that it's a short appointment, but actually a lot is happening, or actually you're quite unwell or something like that. But that's fine. So there's a certain number of appointments per year. I can't remember the exact number, but it's roughly, if you do once a week psychiatrist, that will be the same fee. So the rebate won't really change. So obviously the psychiatrist might charge a different fee. If you're seeing them very, very frequently, they might charge you a bit of a lower fee because, it's going to cost you a lot, but also because it's regular, it's a bit regular income for them. So they don't mind charging a bit of a lower fee, right? It's less administrative time, all those other sorts of things. So the private fee can vary a little bit, but the Medicare rebate will be the same. The rebate does increase or change, if you're seeing a psychiatrist more than once a week. Some people will see them twice a week or even 3 times a week. Maybe someone's just very unwell, just had a very difficult 6 months, something like that. So if you need it more frequently, there is a additional rebate thing that it happens automatically with the psychiatrist and the fees. But the most important is that we actually have a Medicare safety net in Australia. Now, this is a very, very important concept to understand. If you have paid more than a certain amount out of pocket for your psychiatrist, after that amount, regardless of how much the psychiatrist charges, you will get about 80 or 90% back per appointment. It's usually about between $1,000 or $2,000. So let's say you started seeing a psychiatrist in February, you saw them for about 6 appointments. By that time, you've reached the safety net and you've spent, $1,000 or $2,000 out of pocket. Beyond there, if each appointment is, let's say, $600, you will get about $500 back from Medicare rather than the usual $200 or something like that. So each psychiatrist appointment after you've hit the safety net should only cost about $100 or so out of pocket. So that safety net is very important for those who claim family benefit in the tax, who are on DSP and a few other categories. The safety net is lower, so you only need to pay about $800 out of pocket at the beginning of the year, and after that, all of your psychiatrist appointments will be 90% rebated, rather than the usual sort of $100 or $200 or however much you get. So it becomes much, much more accessible. And usually the key to this is see your psychiatrist at the beginning of the year, nice and early, get a few appointments done, and then for the rest of the year, your psychiatrist appointments will be much, much cheaper.
Okay, and the start of the year here, because I'm always confused coming from France. Is it like
January?
It's January. Okay, so it's the same thing. Okay, no, because for fiscality for companies, it's like I think it's July. So yeah, I'd rather ask. No, so it's really clear for me. So I think it's good to have those tips. And something which is really tough also is like as a patient is to talk about a treatment and secondary effects. I found that it's sometimes really tough to explain to your psychiatrist, for example, that you don't want to take your pills anymore, or you want to change treatment because you have a secondary effect because I don't know, sexual dysfunction, or you're getting fat or something. And I think it's really tough to have the confidence to say it to a psychiatrist, because we saw it a lot. We have talking group and we have a community. And between bipolar people, we talk a lot about those things, but they're scared to tell their psychiatrist, like, I don't want to take my pills anymore. And I'm always telling them, like, I can understand that you want to stop, but try to talk about it with your psychiatrist, because maybe they're going to find solution with you. And even if you really want to stop, then you can do it little by little and not stop all at once. So how would you help like a patient like being scared to try to do it?
Yeah. Okay, let's think a little bit more about that, because yes, absolutely, patient being scared of doctor. I myself am scared of my doctor sometimes. I'm like, oh, I don't want to tell him that I was eating all this junk food and now I've put on weight, all that sorts of stuff. So it's very normal to feel a bit anxious and a bit scared, because this person has a lot of power and responsibility. We can't really deny that. That's also the reason why doctors get sued and why they pay a lot in insurance, right? So you are putting a lot of trust and faith in this person. And same way that I trust a police officer or I trust a judge, I also am a little bit scared of those people, because we put a lot of faith and trust in them, right? So it's very normal to feel anxious, first of all. What you might be surprised, I mean, I'm a little bit of an anxious person anyway, but you might be surprised, a lot of psychiatrists are also very anxious about their patients. So we care a lot about the people who we treat. We want good outcomes for our patients, and we worry if a patient isn't well. And when you think about it that way, knowledge is power. Knowledge decreases anxiety and worry. So I worry, is my patient, I can even think about it today. Is my patient tolerating her olanzapine? I can just think about it right now. And I'm like, I hope she's okay. I hope she's not doing this. I hope she's not doing that. Unless someone tells me, I'm stuck just feeling anxious and thinking about it. So it's actually really important. And it's very kind and it's very nice of a patient to tell their psychiatrist how they're experiencing the medications, because otherwise psychiatrist is left wondering and very anxious. So it's very important to actually communicate that, and it actually helps us as psychiatrists. It helps our own mental health. The other thing, though, is that the same way that it's tough to experience these side effects, it's also very tough to hear about those side effects. So sometimes unconsciously or whatever, psychiatrists might not want to hear that the patient is experiencing side effects, because it's just not good news, right? And so unconsciously or whatever, maybe psychiatrists accidentally become a bit more closed off to hearing these sorts of things. So it's important to acknowledge that psychiatrists are also human. They don't want to hear that things are not going well. They want to hear that things are going healthy and well. Doesn't mean that we don't tell them, but just that, take to note when we deliver this news as a patient, saying that, look, my lithium is causing this tremor and it's really, I can't write properly. It's becoming a real issue, or I can't type properly. That's really important that we do tell them. And the doctor's response may vary, and that's very normal from the doctor's response too. But we must communicate it. The doctor also has a legal and an ethical obligation to hear it and understand it and document it as well. So there's lots of ways around it. However, I suppose after you've disclosed or after you've said that I'm having these side effects, what now? Well, I want to stop taking my medication. And this is what I think is really important. Apart from very, very rare circumstances where a patient is very unwell and they want to stop their medications because they're so unwell and they want to do something very terrible that might hurt them or put them in very jeopardy, psychiatrists can't do anything about it. It is the patient's choice. It is absolutely your choice or my choice or whoever's choice if they want to continue and not continue medication. There's very, very rare circumstances which that would not be the case, and we would override that choice. And there is a lot of paperwork amongst everything else associated with that because we're violating someone's human rights, right? So it is your right to stop or change or increase or decrease all these sorts of medications. And the job of the psychiatrist or the job of the doctor is simply to translate science into you or into the patient. So that's where it's really important that you actually do see your psychiatrist if you do want to stop medications so that you can make a really good call on it. And so I will tell my patients that, yeah, if you want to stop this medication, this is the pros and cons. This is what could happen. This is what won't happen. And sometimes I need to genuinely say, because I'm not sure whether this medication is working. We're both not sure. And we say, so do we want to continue it or do we want to stop it? You're noticing a little bit of side effect, you're noticing a bit of weight gain, and you're still not very good in your mood, or you're still very stressed or whatever. But maybe this medication is making a big difference for you. So if we stop it, there's a chance of relapse. And that sort of conversation must occur so that you as a patient can make the best decision possible. And then the psychiatrist will be there. They will say, yeah, you want to decrease your medication? Sure, we'll decrease it. We can stop it. And we check in. We see how you're traveling. We check your mood. We check your side effects. Do they get better? Do they get worse? At the end of the day, your psychiatrist is kind of just like your personal scientist. So it's just your person to communicate the information or the science into your decision. The decision, though, is entirely up to the person. The other good thing, which I think you mentioned just earlier, is that actually you might not know that there are a lot of other options. So without speaking to your psychiatrist, you might say, oh, look, maybe it's just not working and I'm just going to decrease and stop it. Whereas really, it's probably not working. Actually, maybe 1 in 3 people it doesn't work. There's another one that might work a lot better for you. And so there's all these other options that you might just not know because you didn't have to go through, 7 years of medical school and another 7 years of psychiatry school to learn all of that. So you're paying someone who has learned all of that and tell that to you. So you might as well find that sort of stuff out for you. The important thing, I think, just to mention in terms of medication is safety. And that's both from the therapeutic aspect of it, but the side effects of it. Our psychiatric medications are not easy medications to be on. They are rough. They are hard medications to be on. And despite a lot of growth in the science, we haven't had any kind of silver bullet medications really that are very, very effective and yet are very friendly from a side effect profile. So it is common to experience side effects, and sometimes those side effects can be so severe that we need to change the medicine. And that is also common. That's not rare. That's very normal, arguably. However, because these medications are very powerful, decreasing, increasing, changing doses, all these sorts of things can be quite dangerous. So the other thing is that you need a scientist who's also insured, who's also, registered, who's all those sorts of things. You need someone there who's in your court who can support you and protect your body and your organs and your reputation and all these other sorts of things.
Yeah, I feel it's really important because when taking pills for me was a difficult thing. At the beginning, when I was diagnosed, I had all those questions of maybe it will work without taking treatment. Should I take treatment or not? I don't want to take it for all my life. This type of question. And basically, what I feel was most important for me was acceptance, to really switch and be like, okay, I'm bipolar, so I accept that I have to take my treatment every day. I accept that I need to see a psychiatrist, a psychologist. I accept that I'm really careful about my sleep. I almost don't drink alcohol, this type of thing. And I know it's difficult, but I really wanted to share that. Also, one of the things I see a lot is not accepting. And when things go well, it's like, okay, everything is going well. I'm gonna stop taking my treatment. But I found it a bit surprising, but also not, because you feel that, okay, you don't need it anymore, but maybe you don't feel problem anymore because you have your treatment. And so the same thing, really, like, and I think it's easy to talk with you, Arjun, because you have this mindset where you're really open about the weakness of the treatment. But it's really, if I wanted to share something, is like, really feel free to tell your psychiatrist if you want to stop. It's totally okay. And try to open yourself. It's hard, but asking for help is also, for me, a part of acceptance, because I need help. I know some people don't. I need some, because I know I'm bipolar and this is how I work. So I really want to, maybe you want to react to that first.
Yeah. Look, you're absolutely right. And sometimes it's better to think about this in a little bit broadly rather than psychiatrists and mental health. Because at the end of the day, bipolar disorder, for example, we're talking about bipolar in particular today. There are other mental illnesses as well. But for example, bipolar disorder has a strong biological, genetic, and a strong environmental focus to it. So do many other medical conditions, heaps of medical conditions, skin conditions, autoimmune conditions, kidney disease, all these other sorts of illnesses that people have and live with. It really sucks because they've got the genetic component to it, they've got this biological component to it, and they have this environmental component to it as well. So, I'll do some disclosure. I have rosacea, which is a sort of skin condition, and I have to take medication almost every day, and basically I will, and sometimes I forget, and it really sucks. And also when it's dry weather outside and it's cold, or if it's too hot and my skin is sun sensitive and all these other sorts of things. And sometimes I even know that I need to spend a weekend at the beach because with the salty, warm, moist air, because it's just healthy for my skin. And I won't notice necessarily that if I stop taking my medicine, I won't notice until weeks or months later that my rosacea is flaring up again. And unfortunately, it's almost got less to do with mental illness and more to do with just this is how the body works and this is how our medications work, regardless of whether it's brain health, eye health, or any sorts of other medical condition. But yeah, sometimes these things just happen, and it is something that you have to manage every day, otherwise it will return. And you'd think that maybe this doesn't happen for operations or for surgery, but even with surgery, it's the same case. You have this, you can have a surgery and an operation to get rid of some, polyps or something like that, but you still have to have your scope every couple of years. And in 5 years' time, some polyps have grown back and you have to do the whole thing again. So it's part of just how our body works. And sadly, I suppose this isn't really communicated that well when we learn about science and medicine and those sort of things when we're in high school and stuff, which is when we kind of learn about these sorts of things, that there's this prophylaxis in our intervention, meaning that we prevent things from happening through our medications, through our operations, all that other sorts of stuff. If that intervention doesn't occur, whether it's a medication or something else, then the chances of a said illness coming back increases. And that's basically the principles of prescribing in a lot of medicine, not just mental health. But I suppose, just like all other parts of medicine, I had to learn through about 3 or 4 relapses of rosacea that I have to take this medication long term. And my dermatologist had to learn that too. We came off the medication together, and about 6 months later, went through some stress. It was a hot day, blah, blah, blah. And it just went really feral and reacted again and all of these other sorts of things. And then the dermatologist was like, okay, we need to take this medication for a lot longer. And that is acceptance, and but it's a journey of acceptance. And I think that journey of acceptance is like, it's very individual, but it's very collaboratively, not just with you, but also with your family and with your doctor. So, and I suppose we learned that it's not even through health, when we think about when we're kids and stuff like that. And, sometimes you don't make a mistake once. You need to make a mistake a few times in order to learn that was a really bad idea. Like speeding, for example, some teenage kids and boys, maybe like myself, we might have done speeding ticket, and then we did speeding again, and we got another speeding ticket, and then a third speeding ticket. And it's not until the fourth one, when I'm on 1 point left and I could lose my license, that I really need to be like, okay, I need to stop speeding. So that journey of acceptance is also very human. And it's very important that we don't, I suppose, pathologize it too much, because that's a really important process that we all need to go through. And a psychiatrist can guide you through that, but our families and our own personal experiences and all these other things are just as important through that journey of acceptance as well.
Yeah. No, thanks for sharing. I think it's really important because it changed the way we see also the barrier between doctor and patient. I want to ask you this last question, Arjun, is like, if you had a magic wand, what would you change in mental health?
That's a great question. So I usually ask this question sometimes when I occasionally will do an interview or something like that as well. But actually, I haven't had that question asked to me in a long time. Look, for me, and I know that I'm a scientist and all these other sorts of things. However, I just feel that the social determinants of health are massive. And there is so much that I see in my patients that has got nothing to do with my patients. It has got everything to do with generations upon generations of discrimination and inequality and poverty and, climate change and these other sorts of things. And it's really, really heartbreaking when I see in my consulting room the very deep personal effects of that. So if I had a magic wand, I would like to change the social determinants of health as much as I can, and whether that's, through some sort of eradicating poverty or having universal education or having like wars and conflicts and all these really unnecessary situations. But even they're not necessarily unnecessary. It's driven by other social determinants, usually lack of resources because desertification, because of climate change and all these other sorts of things. So that my magic wand would be that if we can improve social determinants and basically the well-being of our communities and our societies, if we can improve the quality of life in people as a group, the individual will be far healthier. You'll always need psychiatrists because there's always going to be mental illness and these other sorts of things. But there are so many factors to mental illness, relapses, and all these other sorts of things, which could easily have been prevented and avoided. And arguably that carries so much what we call disease burden, meaning that's what carries a lot of the relapses or the cost associated, not only the financial cost for the person and for the government, but also like the personal cost and the reputational cost and your career, all these other sorts of things that just go askew. So that would be my magic wand. I know it's a big one, but I'm a optimist, so I will aim for something big.
Yeah, thanks a lot, Arjun. Thanks for sharing, and yeah, I hope to see you soon.
Likewise, yes, we'll catch up when we're in Sydney next.
To learn more about bipolarity, go to our website upstage.com, hopestage.com. See you soon.